Okay, now we move on to disturbances in the jaws or bones of the jaw. These disturbances are classified into problems in the mandible, problems in the maxilla, and problems in the temporomandibular joint. Today, we're going to talk about maxillary problems and mandibular problems. Temporomandibular joint is not included in today's lecture. So the problems that can appear in these mandible or maxilla bones, it can be Ignacia, Micrognacia, and Macrognacia. We will talk about the definition of these terms right now. So Ignacia, A refers to absence of something. Gnacia, it means jaw. So Ignacia, it means absence of jaw. We're talking here about absence of either maxilla or the mandible. In the maxilla, it may be part of the maxilla, because as we know that the maxilla is not only one bone, it's like multiple bones attached together. So this Ignacia might occur in one part of the maxilla, whether this will be the maxillary process on both sides of the face or premaxilla in the middle. While in the mandible, it is more common. So the patient might be missing a ramus or a condyle. So again, a small portion of the mandible rather than the whole mandible. If the problem is unilateral ramus missing or deformed with an absent ear due to failure of migration of neurocrest mesenchymal into maxillary prominence, this is an embryological defect that happens during the formation of the jaw. So if there is a failure of migration of neurocrest cells mesenchyme into the maxillary prominences, this will lead to missing ramus and deformed or absent ear, because these cells, these neural crest cells, are responsible for the formation of this part of the face, which is the ramus of the mandible and the ear. Okay, the second definition here is micrognacia. So micrognacia, it means small jaw. It again can affect either jaws. It can be true micrognacia, so the bone is really smaller than usual, or apparent micrognacia or relevant micrognacia, in which we can see it seems to the examining doctor that the jaw is smaller, but it's not actually smaller. So true micrognacia, it has two types: congenital type, that is seen immediately after birth or discovered after birth, and the other one is acquired type that occurs later, a little bit later on. The congenital micrognacia, it is associated with congenital heart disease and Pierre-Robin syndrome. These are conditions that might affect the child and lead to also or be accompanied by micrognacia. It might be also due to deficiency in the premaxillary area or retracted middle third of the face. Mandibular micrognacia may be due to posterior positioning of the mandible or steep mandibular angle or agenesis of the condyle. So it can appear due to multiple reasons, leading to this problem to be congenital or seen right after birth. The other type, which is the acquired micrognacia, this is postnatal, so after the child is born. It might be due to disturbance in the temporomandibular joint region, leading to ankylosis and small jaw. It can also be due to ankylosis of trauma or infection of the mastoid muscle, for example. So the clinical features of those patients with micrognacia are severe retrusion of the chin, steep mandibular angle, and deficient chin button, because everything in this area is pushed back due to defects in this. I'll give you an example of a disease or a syndrome that has micrognacia that will represent this group for you. It's called Pierre-Robin syndrome or Pierre-Robin sequence. It's a malformation complex that can occur as an isolated finding or as a component of various syndromes or developmental anomalies for the patient. And that's why it might be called sequence, because it contains more than one problem. So clinically, up to 22.7 per 100,000 births will have this defect. Let's say 23 patients per 100,000 will have this defect. The fetal malposition and interposition of the tongue between the palatal shelves is considered the etiology of this syndrome. So during the development, before the palate is developed, the tongue will be in a very high position between the two palatal shelves. And when the time for the palate to form comes, the tongue usually is depressed down. So the palatal shelves come from both sides and meet right in the middle, forming the palate. But in this case, Beer-Robin sequence, there is a failure in the palatal shelves meeting in the middle, and the tongue will stay in its high position. So the infants usually present with severe micrognacia and mandibular hypoplasia. There is a U-shaped cleft palate. So there is an opening in the palate because the tongue will not allow the palate to form. It's common, but it's not a constant feature. So not all the children will have it, but it's quite common. And in some instances, the palate is not clefted, but it's very highly arched because the palatal shelves might go over the tongue to close, leading to a very, very highly arched palate. The patient will also have what's known as glossoptosis, which is displacement of the tongue towards the pharynx or backwards. This is a result of a retropositional attachment of the genioglossus muscle caused by the retrognathic mandible. So you have to think about your anatomy when you're trying to understand this here, because the muscle attachment is usually to the bone. We have a problem in the mandible, so all the muscles that attach to the mandible should be in a posterior position because the mandible itself is sitting in a posterior position. So this posterior attachment will lead to the tongue being pulled to the back. This is known as glossoptosis. I will show you a picture now so you can see what we're talking about. We also have respiratory and feeding problems. These are prevalent and may result in episodic airway obstruction. This is expected because you have a cleft palate. Infant hypoxia because of problems in breathing. Sometimes malnutrition, it's very also evident if it's not taken care of, and failure to thrive. So the child will stay very, 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 very small, the newborn. This is a child with this syndrome, as you can see. A profile picture will show you that the mandible is very, very, very tiny. It seems like it's absent altogether because it's sitting to the back. If you look at the frontal view, there is no chin button. It seems like the chin is connected to the neck immediately. And once you open the oral cavity, you can see that the tongue is retracted backwards. And there is an opening in the palate or a cleft palate. So this picture here is maybe a little bit small, but you can see that the position of the mandible here is sitting backwards. And there is glossoptosis, so the tongue is pushed to the back. And the tongue obstructs the palatal function from happening, leading to U-shaped palatal clefts. And the head looks like very typical appearance of this child. So this is a complicated condition that we need to take care of this child, and we need to try to fix or manage these problems as soon as possible after the child is born. So there should be a constant medical supervision for these children to watch out for airway obstruction and hypoxia, cor pulmonale, which is infection of the lungs, gastroesophageal reflux, bronchopneumonia, and exhaustion, because the newborn is not able to breathe normally, which is quite exhausting, if you will. So we should repeat conservative repositioning of the infants to fix the position of the breathing and help it. Pulse oximetry and apnea monitoring, they are prudent during a neonatal period, just to be very careful about the level of oxygen in the body and ability of breathing. And this should be in a hospital setting, because it's if any problem should occur, the management should be immediate and fast. In severe cases with chronic upper way obstruction and failure to thrive, intraoral or nasopharyngeal airway placement should be done to help the children thrive or grow a little bit. After the first few months of life, however, mandibular growth, mandibular growth takes place. Improved control of the tongue muscles also is evident. This will result in significant abatement of symptoms, so the child will be able to latch to the mother breast and use their muscles to feed. Also, the mandible will grow, which will help the symptoms improve. So growth of the mandible is remarkable during the first 4 years of life, and usually a normal profile is often achieved between 4 and 6 years of age, which is good news for everyone. Now moving on to macrognacia, it means abnormally large jaws, mostly due to pituitary gigantism, which is a problem in the pituitary gland leading to much more release or secretion of hormones, usually growth hormones and so on. It may affect both jaws. The maxillary enlargement is evident in Paget's disease of bone, and it leads to what is known as liontesis ossea, which is the appearance of a lion or a lion face. The lion does not have a nasal bridge, which is something that we will see in those patients because the maxilla is enlarged. So the nasal bridge will completely disappear, leading to appearance of a lion. Mandibular enlargement is seen in a disease called chiropsism, which is a children's disease in which the jaw will become very, very enlarged, the lower jaw especially. We may also see these conditions in acromegaly. This is another type of endocrinal problems in which we have large jaw, large hands, and large head. So Micrognacia is treated by surgical correction of the defect, bone filing, and only surgery can treat the problem, and of course, control of the hormonal issues. This is a picture here of, this is an illustration. On the left side, we have an illustration showing you the difference between a normal size face and enlarged jaw face. So you have an increased frontal pulsing, brow furrow will appear here, enlargement of the base of the nose as well, with thickening of the nasolabial sulcus, thickening of the lips, and parotid hypertrophy and loss of oval facial features. These are acromegaly features. This person here shows acromegaly. He has a very large face, and you can see in the X-ray he has an extremely large lower jaw. And this is an illustration of a profile of a person with acromegaly. We have some examples of conditions that might appear in the jaws. The first one is facial hemihyperatrophy or hyperplasia. So facial hemihypertrophy or hyperplasia is an asymmetric overgrowth of one or more body parts. So one part of the body will grow, the other one, the counterpart, will not grow. It's usually associated with syndrome, so it's not an isolated case. The etiology might be hormonal imbalance, incomplete twinning, or chromosomal abnormalities, lymphatic or vascular abnormalities, or neurogenic abnormalities. So it has many etiological factors. It may be complex hemihyperplasia, which has an involvement of the entire body only half of the body, or it might be simple hemihyperplasia, which involves only a single limb, whether it's a lower limb or an upper limb. And we have hemifacial hyperplasia, which involves one side of the face. So clinically, it lies in the name. We have an enlargement of one side of the face. Females are affected more than the males, and the right side is affected more than the left side. But it's not in 100% of the cases. Oral manifestations will show as an increased crown size, root size, and also the entire tooth. Rate of development of the teeth is also affected on the affected side. They grow faster than their counterparts. Unilateral enlargement of the tongue, so half of the tongue is enlarged, and there is enlargement of the lingual papilla and buccal mucosa on the affected side. The differential diagnosis is fibrous dysplasia and neurofibromatosis. Both of them are connective tissue problems, and the treatment is cosmetic repair. So this is something for the plastic surgery department, and mostly surgical treatment. We have a picture of a patient with facial hemihypertrophy or facial hemihyperplasia. So this part of the face is completely enlarged. You can see that the eye is bigger, the jaw is bigger, and it causes a tilt of the face because this area is enlarged. You can see here in the X-ray, I'm not sure if this X-ray is for the same patient, but however, we can see that the jaw is a little bit bigger on this side. You can see that the bone size here is quite large compared to this one here. And so it causes a shift or asymmetry in the face, an obvious one, obviously. Another condition, which is the opposite of facial hemihypertrophy, this is called facial hemiatrophy or Berry-Romberg syndrome. So this is a slowly progressive atrophy of the soft tissues of essentially half of the face. We have progressive wasting of subcutaneous fat. Afterwards, it's followed by atrophy of the skin, the cartilage, the bone, the muscle. So the entire face will crumble like an old litter. May be spread to one side of the neck, sometimes the entire body. The etiology in the generalized type, they might have cerebral disturbances leading to increased and unregulated activity of the sympathetic nervous system, which causes the problem. They might have trauma or infection. It may be hereditary. Sometimes it's maybe due to peripheral trigeminal neuritis. In localized condition, they might have a condition called scleroderma, which affects the skin and the ectodermal tissues in specific parts of the body. So if they have scleroderma, this might affect half of their face, leading to Berry-Romberg syndrome or facial hemiatrophy. So clinically, the disease begins in the first decade of life, so teenage years, and it may last for 3 years before it becomes quiescent or before it stopped progressing. As we mentioned, there is an atrophy of the skin, subcutaneous tissues, muscles, bones, and cartilage on one side are affected. We have basilar kyphosis, which is parts of the bone will be affected, bones of the back, mishap in ear or small ear on the affected side, dark pigmentation of the affected side, and trigeminal neuralgia and facial paresthesia. Of course, the nerves might also be affected, leading to this trigeminal neuralgia and facial paresthesia. Orally, you can see atrophy of half of the lip, half of the tongue, shorter ramus, and body of the mandible, which will result in malocclusion, delayed eruption of teeth on the affected side, which is the opposite of exaggerated growth in hemihyperplasia. These are 2 patients affected by this disease. Half of the face is atrophied or crumbling in a way, but this patient has a good it became better when this stopped progressing. So he escaped with some damage, but not very severe, as we see in this very beautiful boy here. So this profile of the normal part of the face is just perfect. This is the frontal view where we can see half of the face crumbling literally, and the other half is normal. As you can see, there is a shift in the midline. There is a change or asymmetry of the face. So the ear is becoming smaller, the jaw is becoming smaller, the mouth is shifted to the side of the atrophy. And this is a profile of the affected side of the face. It seems like a picture of an old man, while the child here is just, so I hope that this become better like it happened here, because it takes 3 or 4 years starting from the onset time to stop or be quiescent. So let's hope it's become better for this one. Another condition is coronoid hyperplasia. This is an uncommon condition that is often associated with a very characteristic feature, which is limited mandibular motion. So the patient will come complaining of inability to move their mandible because the coronoid process is hyperplastic. The cause is, again, idiopathic or unknown, but a history of trauma is present in many of the cases, leading to the suggestions that this might be the contributing factor to this process. It's a hyperplastic process. So the coronoid process is actively forming new tissue, although it has been suggested that maybe neoplastic. Some scientists suggested that this is not a hyperplasia, it is a neoplasia or formation of tumors, but it's a matter of experiments and research. It's not conclusive. Most cases have been reported in males, suggesting an X-linked condition. So clinically, oftentimes this condition is seen bilaterally on both sides. Very few unilateral enlargement have been seen. It results in limited mandibular movement, which is progressive over time. So it starts and it gets bad with time. It's usually painless, not associated with facial swelling or asymmetry. So the only problem that the patient will tell you is that they cannot move their mandible. And you can see now why is that. This is a patient with coronoid hyperplasia. You can see here that the coronoid process is enlarging until it's becoming higher than the level of the maxillary process here on both sides, because it's usually bilateral. So the mandibular movement is typically affected. They cannot move their mandible very freely like before, because the position here is quite high. In the normal situation, it should not be that high, it should be lower than this, so you can open and move to the sides and so on and so forth. This is a picture of an enlargement of the coronoid. It looks a little bit strange, and maybe that's why they suggested this could be a neoplastic growth rather than hyperplastic growth. So I guess the treatment for that should be surgical intervention. There is another condition that is called condylar hyperplasia. So if you go back to this picture, let's just go back. This is the coronoid process, and this is the condylar process. Usually the coronoid process sits lower than the condylar process. Now we talked about the coronoid hyperplasia leading to limitation of movement. Now we will talk about condylar hyperplasia, and we'll see if it's similar or not. This is, again, is an uncommon malformation of the mandible created by excessive growth of one of the condyles. So it is not 100% bilateral. It could be unilateral in one condyle. It may be due to local circulatory problems in the blood vessels or endocrinological disturbances. Trauma may also be a factor. And in this case, sometimes it's very difficult to distinguish from hemifacial hyperplasia because clinically they might look similar. We have facial asymmetry because we have a unilateral problem. It's not on both sides. We have prognathism, which is protrusion of the jaw towards the front. The patient might have cross-bite, sometimes open bite. So radiographically, it's very quite variable. Unfortunately, it's not a unique picture. Patients have an enlargement of the condylar head. Others show elongation of the condylar neck. It's not one picture that you will see. It's variable, so you have to be alert to look at different expectations for this condition. Hyperplasia of the entire ramus is also being reported before. That might be part of the condition as well. Okay, so if we look at the histology, during the active period of the condition, there is proliferation of the condylar cartilage, and this is evident histologically. But once the condylar growth has ceased, the condyle has a normal histological appearance of cartilage. There is nothing different than the normal condition. So it depends at which stage the patient is presented in the clinic. If we talk about the treatment for this condition, the good news is that this condition is self-limiting condition, so it stops by the end of the growth period. So the treatment after that is determined by the degree of functional difficulty and aesthetic change. If the change is severe, then we can do intervention. If it's not that severe, it does not affect the appearance of the patient or the function of the oral cavity, it can be kept as is. If you need to treat, you can do unilateral condylectomy, which is cutting the condyle on the affected side, or unilateral or bilateral mandibular osteotomies. And these are surgical procedures that are done to the bone of the jaw to shape it in a better way, to get it back to as normal as possible. Sometimes you need to do maxillary osteotomy, might be needed. This bit should be done with concomitant orthodontic therapy because the malocclusion is, in many of the cases, will not correct itself. You have to correct it by orthodontic treatment. But both treatments should be done at the same time. This is a picture of a patient with condylar hyperplasia. You can see that the condyle here is enlarged, leading to pushing of the jaw and elongation of this part of the mandible here, shifting the midline. They might have an open bite on this side, and the teeth, you can see that the teeth are affected. They are short here, they are elongated here because they need to compensate for what is happening. And in the face of the patient, you can see there is a shift for the midline. If you draw a line in the middle, it is shifted to the left side. We will talk about another problem that is seen in the jaw bones, that is exostosis. These are localized bony protuberances or elevations that arise from the cortical plate of the bone. And these are benign growth, frequently affecting the jaws. Clinically and radiographically, we see most of the cases in adults. We don't see them in children. They could be seen buccally or palatally. So if they are lying buccally, buccal exostosis occur usually as a bilateral row of bony hard nodules. They are along the facial aspect of the maxillary or mandibular alveolar ridge. They're quite high in the bone, and they are usually asymptomatic unless the thin overlaying mucosa becomes ulcerated from trauma. So if the mucosa is kept from being traumatized or ulcerated, you don't have any symptoms, you just see them lying in the patient mouth with no effect. Palatal exostosis or palatal tubercles, they are similar bony protuberances that develop from a lingual aspect of the maxillary tuberosity. So the maxillary tuberosity, this is the area behind the molar teeth. In the lingual aspect of it, if we have this tubercle, this is called palatal exostosis. They are usually, again, bilateral and may affect only one side in some cases. They are more common in males than females. The patient with buccal or palatal exostosis will also have palatal or mandibular tori. These are, again, bony protuberances, but the position is different or the location is different, and that's why they have a different name. So palatal torus is seen in the midline, and mandibular torus is seen in the lingual aspect. Solitary exostosis may occur, so sometimes the patient might get only one bony protuberance. These are not very common, but they are possibly due to a local irritation, like, for example, alveolar bone beneath a free gingival graft and skin graft. This area had been exposed to irritation or a new tissue because it's a graft tissue. In these areas, we might notice solitary exostosis. If we have enough excess bone present, exostosis may exhibit a relative radio-opacity on dental radiographs, but this is only if they are thick enough to be presented in the radiograph. Otherwise, you will not be able to see them. The picture here, the clinical picture, sees this is an extreme case of palatal exostosis and mandibular exostosis and maxillary exostosis. This is a palatal exostosis, which is in the lingual aspect of the retromolar bed or maxillary tuberosity. And it is thick enough to be shown in the X-ray. So when you took, when they took an X-ray, this is evident here. And in this case here, sometimes the thin mucosa over these bone extensions might be ulcerated due to trauma. So if you look at them histologically, you will see a mass of dense lamellar cortical bone with a small amount of fibrofatty marrow, but it's not as much as the bone. So what about the treatment of this condition? It must be removed if it repeatedly has been exposed to trauma or was the reason for painful ulceration. In this case, you have to do surgical removal. Also, it's sometimes important to remove them to accommodate dental prosthesis or to allow for proper flap adaptation during periodontal surgery. Otherwise, if they are not causing any problem for the patient or any concern for the patient, they can just be left alone. Now let's talk a little bit about tori. So tori, starting with torus palatinus, these are common exostosis. So they are, again, exostosis, very similar in structure, and they are typical to the exostosis, but they occur in the midline of the vault of the hard palate, and that's why they have a different name. So torus palatinus is an exostosis that appear in the midline of the vault of the hard palate. The etiology is debated to be genetic versus environmental factors. Some scientists say it's both these factors together, but we don't have a conclusive etiology. So if you look at the clinical and radiographical picture, it presents as a bony hard mass that arises along the midline suture of the hard palate. It has higher prevalence in Asians and Inuits, Eskimo people or populations. Female to male ratio is 2 to 1, so females are more affected in this case. and it appears later in life. It appears later in life, and also some of them may undergo resorption or remodeling in response to decreased functional stresses. And the torus palatinus does not usually appear on routine dental radiograph. You can only see them by clinical examination, of course, because you can see them with your naked eye, but in the X-ray, if you are an X-ray specialist or you did not see the patient and you got only the X-ray, you will not be able to tell that they are there. The histology is the same as exostosis. Again, they are mass of dense lamellar cortical bone. The inner zone of the trabecular bone is sometimes seen, so it's not only dense. Sometimes you may see trabecular or spongy bone in the middle. The treatment in edentulous patients, the torus is sitting in the midline of the palate, so it might be needed to surgically remove it to accommodate a denture base for the upper jaw. And also if it becomes repeatedly ulcerated or if it interferes with oral function, these are all indications for removal, surgical removal. But otherwise, if it's small and if it's not causing any disturbance for the patient, it should not be, it does not need to be removed. The counterpart for torus palatinus is torus mandibularis. This is a common exostosis that develops along the lingual aspect of the mandible rather than the buccal, because the one on the buccal is called mandibular exostosis. So it appears on the lingual aspect of the mandible, and these are probably multifactorial, again, including both genetic and environmental influences, very similar to torus palatinus. Again, these present as bony protuberances along the lingual aspect of the mandible above the mylohyoid line in the region of the premolars, usually. And there is 90% of the cases are seen bilaterally, and only 10% will see on only one side. It occurs as single nodules or multiple lobules paralleling the teeth. I will show you a picture. Radio opacity superimposed on the root of the tooth if you take an X-ray. So the histology is the same as the other tori and exostosis, and the treatment is again surgical removal that might be required to accommodate a lower full or partial denture. Otherwise, they don't need to be removed. So you have a picture here showing you palatal tori or torus palatinus sitting at the center. And again, I'm showing you extreme cases. It might be smaller than that. Not all of them are this big. And this here as are bilateral mandibular torus mandibularis. Again, they are sitting against the premolar area or the canine area, and they're quite big. If you take an X-ray, occlusal view X-ray, you can see them. This is not the same patient, but you can see them quite opaque here. So these are torus mandibularis. This will bring us to the end of today's session. Thank you very much. I hope you have a good evening. Wassalamu alaikum.